So good morning, everyone. Welcome to the last News of the Day press briefing at this year's ASCO annual meeting. I'm Dr. Richard Shilsky, ASCO's Chief Medical Officer. I'll be moderating today's briefing. Before we begin, I just really want to thank all of you for attending and for the great coverage and stories you've been producing. You really are doing a tremendous service to people and cancer patients and doctors all around the world by helping us to disseminate the information that's being presented at this meeting. So thank you for that and for the work you do all year round. We have a packed press briefing this morning. We'll try to get through everything and leave plenty of time for questions. 5 studies will be highlighted today discussing new insights for treatment of multiple myeloma, lung cancer, and breast cancer. As usual, we have some ASCO experts on the podium. Dr. John Haymack is here. Dr. Michael Sable is here. Dr. Hal Burstein will be joining us shortly. As usual, I ask that you please use our ASCO affiliations for purposes of attribution in coverage of this meeting. So without further atu, I'm going to introduce our first speaker, Dr. Wanheng Zhao, an Associate Director of Hematology at the Second Affiliated Hospital of Xi'an, Jiaotong, University of Xi'an in China. And he will highlight an exciting clinical trial about a new type of CAR T-cell therapy for the treatment of relapsed multiple myeloma. Dr. Zhao.
Good morning, ladies and gentlemen. My name is Wanheng Zhao. I am a clinical doctor at Hematology Department of the Second Affiliated Hospital of Jiaotong University in Xi'an, China. Firstly, I would like to thank ASCO for giving us the honorable opportunity. This study was sponsored by Legend Biotech. Multiple myeloma is a liquid cancer derived from malignant plasma cell in bone marrow. This cancer has high incidence in the U.S. Precision immunotherapy, like CAR-T, had been shown to be very effective in treating leukemia and lymphomas. Legend Biotech has invented a bispecific CAR-T platform, which we are using to treat relapse or refractory multiple myeloma patients. In our current ongoing trial, we have observed a revolutionary, quick, and durable remission in most multiple myeloma patients. We first screen and enroll patients, then isolated immune cell from patients, and engineering with a CAR molecule in the lumbar. This is just like placing a GPS on the immune T cells, which is now capable of fighting cancer cells. We call this unique CAR design LCAR B38M in our hospital. Patients were infused with 3 doses of engineered T cell at D0, 2, and 6. You can see on the left half of slide, the CAR T cell now bound to myeloma cell under microscope. So far, 35 multiple myeloma patients have been treated in our CAR T trial. First, there are 19 patients who were treated and last 4 months. 4 months ago, in these 19 patients, 14 patients have reached stringent complete response, SCR, based on International Myeloma Working Group criteria. When we submit our ASCO initial abstract in February this year, this number was 6, but now the number has reached 14. In other words, during the past 3 months, CR rate has increased from 92% to 74%. There are 6 additional patients who have reached very good partial remission criteria, very good PR. This shows very clearly that while time goes on, the therapeutic efficacy improves progressively. Second, there are 5 patients who received treatment for more than 1 year. These 5 patients all remain SCR as of today. There has no case of relapse among patients who have reached SCR. Lastly, there are 6 patients who have been treated for less than 4 months. They have shown various degrees of response. Safety is our top focus. Unlike what has been seen in ALL CAR-T trials, we have never observed any sign of neurotoxicity, including cerebral edema. We also observed much milder cytokine release syndrome, CRS, than frequently reported in leukemia CAR-T trial done by others. Among all 35 patients, 6 patients were free of any CRS. 17 patients had grade 1, 10 patients had grade 2 CRS. There are only 2 patients who experienced grade 3. There is no grade 4 and 5 CRS, and there is no treatment-related deaths. In summary, our results have showed a quick and reproducible therapeutic efficacy in refractory or relapsed multiple myeloma disease. Long-term follow-up of early treatment patients shows durable and stringent complete remission. Our technology is not only efficacious, but also very safe. USND had been planned, and the technology will be validated in US under regulation of FDA. Thank you very much. For questions regarding to the product, you may ask Dr. Frank Fan of the Legend Baltic. Thank you again.
Thank you so much, Dr. Zhao. So this is a very exciting but complex technology and treatment program, so I'm going to ask Dr. Sable to offer some comments.
So first, I would just like to congratulate the investigators on a fantastic trial. Not only just the implementation of the trial, but the science behind it is really getting to be quite revolutionary. I think what you're seeing here is the expansion of immunotherapy to cancers that really are refractory to chemotherapy, and how immunotherapy is now really providing hope to a lot of patients with cancers that were not really responding to our standard chemotherapies. But what I also think is really fascinating about this and similar forms of research is you are now seeing the merger of immunotherapy with precision medicine. This is really the epitome of personalized medicine. And this takes us in a direction away a little bit from the checkpoint inhibitors. And those are fascinating as well and have had tremendous results. But as you know, those are relatively nonspecific. They're asking the patient's own T cells to recognize and destroy cancer cells, and that's not really going to work for every cancer type and every patient. And now you see this ability to combine personalized medicine and immunotherapy to really gear the T cells to recognize that patient's own specific tumor. And I think this really opens up the door for really using this sort of precision immunotherapy to expand the potential of immunotherapy to a wider net of patients, and that's really fascinating. Obviously, there's more research to be done, not just to see what the feasibility is and validate these results, but also in terms of making this type of therapy more accessible to a wider array of patients and learning how we can apply it to other types of cancers, including solid tumors.
So, Mike, I wonder if you could just expand on one point, since you used the term revolutionary science. And could you describe to the audience what about this approach with CAR T cells that is different from some of the other approaches we've been hearing about, and what do you consider about it to be revolutionary?
So we have struggled. It is easy to say that immunotherapy is novel and new, a fad. I've seen several articles that have been coming out sort of saying, oh, immunotherapy is this new treatment. But we've actually been studying not just this form of immunotherapy, but other types of immunotherapies for decades. And it took quite a while to even get to this point where we're seeing so many sort of breakthroughs. But we've struggled with the idea of getting T cells to actually recognize the cancer cell and really form that bond, that latch that allows it to be an effective killer cell. So we've had a lot of studies in the past where we can get the T cell to recognize the cancer, but that doesn't always translate to the clinical benefit. Now you're seeing that advance that comes through a better understanding from the basic science research of how T cells operate that allows for greater killing by the T cell, and that's translating to these response rates, which are really just fascinating in a very difficult to treat cancer. So yes, I would say that this is really the next big forward step in this type of technology.
Thanks. So we'll have time for questions about this at the end of the session. I'm going to go on to our next presentation, which I don't mean to in any way diminish the importance of this next presentation, but the field is moving so quickly these days, as you can tell, that this is almost, this is old-fashioned immunotherapy, even though it's really still very new and exciting. So the next presentation will highlight findings from a randomized phase 2 trial comparing nivolumab to nivolumab plus ipilimumab for treatment of patients with relapsed mesothelioma, a very rare form of lung cancer and one that is very difficult to treat and for which there are very few effective therapies. So the lead author is Dr. Arnaud Cherperil, head of the Pulmonary and Thoracic Oncology Department at the University Hospital of Lille in France.
Thank you very much. Good morning, ladies and gentlemen. I hope I do not look too much like prehistoric guy today. So it's my pleasure and honor to present you on behalf of my colleagues and friends from the French Cooperative Thoracic Intergroup the result of a randomized phase 2 trial, MAPS2, assessing second or third line nivolumab versus nivolumab plus ipilimumab in malignant pleural mesothelioma patients. So malignant pleural mesothelioma malignant pleural mesothelioma is aggressive and quite rare cancer, even if because of its links with asbestos, we could expect an increase of incidence due to the wide use of asbestos still in many countries. And there is no validated curative treatment so far. Moreover, there is no treatment for patients beyond first-line chemotherapy based on pemetrexed, and this is responsible for a poor outcome of this patient with a disease control rate usually below 30% and a median overall survival maximum of 6 to 9 months, usually with all the treatment we have so far as second or third line treatment. Anti-tumor immunotherapy by immune checkpoints, such as anti-PD-1, combined or not with anti-CTLA-4, may improve the prognosis of this patient, as suggested by the result we had already in melanoma patient and in lung cancer patient, and also based on some preliminary data obtained with anti-PD-1 pembrolizumab in mesothelioma. In this randomized non-comparative phase 2 trial, we recruit patients with validated histological diagnosis of malignant pleural mesothelioma. with unresectable cancer with documented progression after maximum 1 or 2 lines of chemotherapy, including pemetrexed platinum, with measurable disease and good performance status, PS01. The patients were randomized to receive either anti-PD-1 nivolumab 3 mg kilo every 2 weeks, or nivolumab same dose plus anti-ipilimumab 1 mg kilo every 6 weeks. The patients were treated until progression or unacceptable toxicity, or maximum 2 years of treatment, and they were reassessed by CT scan every 12 weeks. The first endpoint of the trial was the disease control rate at 12 weeks of treatment. Secondary endpoint includes the assessment of overall survival, progression-free survival, safety, toxicity, and biomarkers. We were able to recruit very quickly 125 patients in 5 months. Most of these patients were male, in their 70s, good performance status, PS01, and with epithelioid subtype of mesothelioma. The compliance to the treatment was really good in both arms, and the adverse events were rather mild, even if we observed slightly more severe adverse events in the combo group, 18% versus 10%, and 3 related deaths to the treatment were reported by local investigators in the Nivo plus EP group. In the first 108 eligible patients, according to the statistical plan of the trial, we assessed the first endpoint of the disease control rate, and the target value was 40% in this trial. We were able to obtain 44% of disease control rate in the nivolumab arm and 50% in the Nivo plus EP arm. Moreover, we observed a shrink of the tumor in 80% of the patients treated by Nivo and 26% with Nivo plus EP. This is the result after a limited median follow-up of 10.4 months. Mature progression-free survival data show a very nice result of 5.6 months of PFS in Nivo plus EP arm. I must remember you that with first-line chemotherapy, usually the PFS is around 6 months, and we obtained 4 months in the Nivo arm. More interestingly, in the preliminary median overall survival assessment, we were able to measure the overall survival of 10.4 months with nivolumab, and a very outstanding result of not reached value for the Nivo plus EP arm. Moreover, when you look at the patient with disease control of the cancer, they have a really exceptional overall survival. In conclusion, in this trial, we show that both nivolumab alone, but also nivolumab plus EP arm, reached their first endpoint in second and third line malignant pleural mesothelioma patient, increasing meaningfully the 12 weeks disease control rate. Moreover, the patient from both arms of this study seems to have prolonged median overall survival compared to all previous reports in this setting. The toxicity was globally manageable, even if we report 3 potential treatment-related deaths in the combo arm. The mature survival, quality of life, biomarkers data, and subgroup analysis will be presented next autumn, 1 year after accrual of the last patient. In conclusion, we think that immunotherapy by nivolumab, combined or not with ipilimumab, may provide new therapeutic option as second and third line treatment for this relapsing malignant pleural mesothelioma patient with very bad prognosis so far. Thank you very much for your attention.
Thanks very much. So again, I'll ask Dr. Sable for some comments and context about this presentation.
So I agree with your comments initially that it almost seems, that this is old. But I think I need to emphasize that this is sort of amazing in that we're seeing the checkpoint inhibitors and the use of immunotherapy now expanding beyond just melanoma or other cancers that we thought were susceptible to the immune system. And here you've now seen the second abstract, second presentation of an incredibly difficult to treat cancer that had very limited options with cytotoxic chemotherapy that have shown really dramatic response rates and potential with immunotherapy. And we're learning more and more about how susceptible cancer might be to the immune system. When many of us started in a career in immunotherapy, everybody said, well, then you need to treat melanoma because that's really the only cancer that is susceptible to the immune system. And most immunotherapists, including myself, for example, are melanoma specialists. And I think what's incredible here is that you're really seeing the expansion of that research done within the melanoma arena expanding to these other cancers. And this is not the only example of that. Throughout ASCO this year, you may have seen the use of checkpoint inhibitors with sarcoma, triple-negative breast cancer, GI malignancies, cancers that nobody several years ago thought immunotherapy would ever be a potential treatment for, and now you're seeing that. And I think this is also just a great example of how basic research in one cancer can really expand across the field of oncology, and why basic science research in these arenas just is so critical. The exponential explosion that you're seeing now with the checkpoint inhibitors across a wide array of tumors just shows the benefit of that type of research.
So I'd like to just follow up with you, and John, feel free to comment as well as a lung cancer expert. So obviously, a lot of research going on about biomarkers that might be able to identify patients who might be most susceptible to these sorts of treatments. Anything that we know about mesothelioma in particular with respect to PD-1 and PD-L1 expression, tumor mutational burden, MSI status, any of the biomarkers that are emerging now?
Yeah. So first thing, and I agree with the comments previously that this really is an important advance, because for this tumor type, the only treatment we had up to this point was a chemotherapy regimen, pemetrexed and platinum. And I can tell you that in treating these patients regularly, it really is frustrating to have one option that is of limited duration and benefit, and then have nothing afterwards. So this, while this does not create this as an absolute standard, it gives us clear path here that this is an active regimen for these patients that desperately need a new therapeutic option. So that's a real advance. Now, when we think about biomarkers for immunotherapy, there's a couple of things that have proven to be promising in lung cancer, melanoma, and other diseases. One of them is just PD-L1 levels. We know that mesothelioma overall does not express extremely high levels of PD-L1 compared to other tumors. But the data suggests that the combination of the two immunotherapy agents, nivolumab and ipilimumab, may broaden the set of patients who may benefit from this immunotherapy regimen. The second is a marker called tumor mutation burden. So essentially the idea is that the more mutations that a tumor has, the more that the immune system can recognize it. Mesothelioma, compared to most of these other tumors that are highly immunogenic, that the immune system sees like melanoma and lung cancer, actually has a relatively low tumor mutation burden. It doesn't have a lot of mutations, but it happens to have them in certain genes that really drive it. So it was not obvious that immunotherapy was going to work here. It wasn't readily predicted. So that's why I think it's so encouraging that in this tumor type that has so few options and we weren't sure that immunotherapy was going to work, this is clearly showing a significant degree of activity and benefit for a broad set of mesothelioma patients.
Great. Thanks. That's really really helpful perspective. So we're going to go on to our third presentation. I see Dr. Mock made it back from the lung cancer session. And he will discuss the results of a randomized phase 3 trial of the second-generation EGFR inhibitor dacomitinib versus gefitinib, which was the first of the first generation EGFR inhibitors in advanced non-small cell lung cancer with EGFR mutations. Tony Mock is well known to many of you, I'm sure. He's professor and chair of the Department of Clinical Oncology at the Chinese University of Hong Kong in Hong Kong. Tony. Thank you.
Thank you very much, and thank you for the kind invitation to share the data on this study, namely Archer 1050, which is a direct head-to-head comparison of dacomitinib versus gefitinib as a first-line treatment for patients with EGFR mutation. Now, this is my disclosure. Now, a bit of background. Dacomitinib is a second-generation TKI. By that, it implies two characteristics. First is irreversible bondage with the EGFR receptor. Second is a pan-HER inhibition, including HER1, HER2, and HER4. With this combination, it implied more potent inhibition of the EGFR. in one single-arm phase 2 study that Pasiani and I had conducted, namely the Archer 1017, it had demonstrated the fact that for patients with GGF mutation, we have a response rate of 75.6% and also a median progression-free survival of over 18 months. Based on this data, we're quite confident that to make the hypothesis that this may be more efficacious than gefitinib, and this formulate the background for this randomized phase 3 study. Study design is actually quite straightforward. Patient has to be treatment naive, both TKI and chemotherapy, good performance status, and the patient actually do not have the CNS metastasis. Why is this different from other study? Well, at the time when we designed this study, we were not quite sure the dacomitinib efficacy in the brain. As well as for gefitinib, that the efficacy is actually marginal for CNS. So for that reason, for the fairness of patient, we decided to exclude patient with the brain metastasis. Randomized eligible patient, 1-to-1, dacomitinib 45 milligram versus gefitinib at a standard dose of 250 milligram daily. 2 stratification factor, including the ethnicity, Asian versus non-Asian, as well as the mutation type 19 versus 21. Now, the primary endpoint is actually progression-free survival. And this is actually by independent review board, the blinded independent review. And secondary endpoint include the progression-free survival by the investigator that I will share with you. The characteristics actually quite balanced between the two arms in terms of age, gender, ethnicity, also ECOG status and smoking status. Just to highlight the fact that we have predominant Asian as expected, approximately 75% of all enrolled patients were from Asia. And then approximately 65% of the patients were never smokers. This is quite classical of any first-line study on EGFR TKI. This is a primary endpoint. It's actually, we have a very positive study. We reached the primary endpoint with the median progression-free survival of 14.7 months versus 9.2 months. The hazard ratio is 0.59. This is very close to what we anticipate at 0.667 in the beginning. And the p-value is also highly significant at less than 0.001. There are 2 features I would like to highlight to you about this Kaplan-Meier survival curve. First, it overlaps in the first 5 to 6 months, but then after they start to separate. And then the separation of 2 curves continue. Even at the arbitrary endpoint at 24 months, it was 30.6% of patients are progression-free versus only about 9.6% of patients are progression-free. The difference at 2 years is almost like 20%. Now, the response rates are similar, which is about 75% on the dacomitinib and 73% on the gefitinib arm. However, you can see that from this waterfall plot curve that the depth of the response is actually higher with the dacomitinib, which implies it's a more potent inhibition of the EGFR, which is exactly what we have expected as well. And then the response rate, as stated, 75% versus 72%, and then the median duration of response is about 14.8 months versus 8.3 months. And then the p-value is also highly significant. Overall survival is immature. At this point, it's only 37% of the patients who had reached the survival event. Now, toxicity-wise, however, because the more potent EGFR inhibition, we're facing higher inhibition of the wild-type EGFR. As a result, diarrhea, paronychia, dermatitis, and stomatitis are more common. Grade 3 toxicity associated with dacomitinib was about 8.4%, 7.5% for the paronychia, 13.4% for the dermatitis, and 3.5% for stomatitis. As compared to the gefitinib arm, the incidence of grade 3 toxicity is actually relatively uncommon. But on the other hand, you may see that there is grade 3 hepatic toxicity related to gefitinib, which is relatively uncommon on the dacomitinib arm. So, as a result, we do require dose modification. We have 2 dose modification levels. One is first level is 30 milligram daily. Second level is 50 milligram daily. And then the gefitinib, there's only 1 dose level, which is 250 every other day. Now, you can see the time to dose reduction is about the same, but the duration of dose reduction is longer, 11.3 months for dacomitinib, 5.2 months with the gefitinib. Approximately 66% of the dacomitinib arm require dose reduction. Approximately 38% from the first dose level at 30 milligram daily, and 28% in the second dose level of 15 milligram daily. But on the other hand, gefitinib dose reduction only required in approximately 8% of the patient. Quality of life, they were able to inhibit the tumor growth, so the lung cancer-related symptoms were reduced in both arms. A little bit more on the dacomitinib arm, but basically they are significant, crossing the 10-point landmark. But on the GI toxicity, as well as the mucositis, there seems to be higher, mean worsening of the quality of life for the dacomitinib arm compared to the arm. But overall, the global quality of life is actually a neutral in both the gefitinib and dacomitinib arm. So allow me to summarize. I think this is the first randomized phase 3 study that compares second generation with the first generation TKI, and we're able to demonstrate an improvement in efficacy. The median progression-free survival of 14.7 months is actually among the highest of all the randomized control study on first-line EGFR TKI. Yes, we do have high toxicity due to the high inhibition associated with diarrhea, skin rash, but then on the gefitinib arm, there seems to be more of the hepatic toxicity. Overall, we do require dose reduction to accommodate the tolerability of the dacomitinib, and this has been done relatively successfully. And at the end of the day, I think we have one additional choice. So in my personal opinion, now dacomitinib should be one of the new so-called options to be considered as a first-line treatment for patients with the EGFR mutation. So thank you very much for your attention. Thank you.
Thanks very much, Tony. So to again offer some comments about this presentation, I'm going to turn to Dr. Haymat.
Okay. Well, I'd first like to congratulate Dr. Mock and colleagues for a well-conducted study. And let me try to give some context for what an advance I think this is for the field. Currently in the United States, we have 3 drugs that we commonly use for patients with the EGFR mutations: gefitinib, erlotinib, and afatinib. And when we compare, we don't, there aren't many studies that compare them head-to-head, but they're typically within 1 or 2 months of each other when we look at them from separate studies. Now, you see here this is more than a 5-month difference in progression-free survival, 5.5 months. So I think from the perspective of doctors who treat lung cancer daily, this is really a substantial advance, more than 5 months increase in progression-free survival compared to just being another tyrosine kinase inhibitor that would join the other 3. I think this would clearly put it at the front of the pack in terms of efficacy. Now, Dr. Mock correctly pointed out that this does come at the cost of some toxicity. And about 10% had grade 3 toxicity involving skin or diarrhea and paronychia. This is substantial. You could see that 38% had dose reduction. That's a substantial number. But I'd like to emphasize that these are not life-threatening toxicities. These are toxicities that doctors who treat this for a living become accustomed to managing. And so I think this provides a clear potential option for patients. And as a physician, I think discussing those different options and the trade-off of toxicity versus efficacy would be entirely appropriate if the drug were approved in the United States. And it's not approved yet, but I think the efficacy here is certainly quite promising when it's compared head-to-head with a standard drug.
John, thanks. I don't want to put you on the spot, and maybe we'll come back to this later, but do you think the dose is too high?
Yeah, so this is an interesting question because if you saw the gefitinib, virtually nobody requires a dose reduction on gefitinib. But you saw the duration of response, how long the drug works for, is substantially longer, about twice as long with dacomitinib. So I guess there's 2 different ways to view it. Is dacomitinib starting so high, too high, if a substantial number need dose reductions, or is gefitinib starting too low because there may be a lot more efficacy if it had started at a higher dose? What I would say is this drug clearly would require close monitoring and careful surveillance by experienced care providers to manage the toxicities, whereas a drug like gefitinib doesn't require so.
Thanks. We'll come back to this perhaps later on. I want to go on and be sure we have time for the other presentations and questions. So the next presentation, also on lung cancer, features the findings from a phase 3 clinical trial comparing alectinib to crizotinib in the first-line treatment of ALK-positive advanced non-small cell lung cancer, to be presented by Dr. Alice Shaw, who's the director of the Thoracic Oncology Program at the Massachusetts General Hospital. Alice.
Thank you, and good morning. So today I'll be presenting on behalf of my co-investigators the primary results of the ALEX study, a global randomized phase 3 study of alectinib versus crizotinib as first-line therapy for advanced ALK-positive lung cancer. ALK, or anaplastic lymphoma kinase, was first discovered as a target in lung cancer about 10 years ago. This target is found in approximately 5% of lung cancer patients, which translates into about 50,000 new cases of ALK-positive lung cancer worldwide each year. The current standard of care for patients with newly diagnosed advanced ALK-positive lung cancer is the first-generation ALK inhibitor, crizotinib. While crizotinib can be very effective initially, most patients will develop worsening disease within the first year of treatment. One of the most common sites of worsening disease is the brain or central nervous system, and this likely reflects the drug's poor penetration into the brain. Alectinib is a next-generation ALK inhibitor that is more potent and more brain penetrant than crizotinib. In early phase studies, alectinib demonstrated robust clinical activity in both crizotinib-naive and crizotinib-resistant ALK-positive patients. In fact, alectinib is already approved in the U.S. and other countries for ALK-positive patients who have failed prior crizotinib. Based on these prior studies, we hypothesized that in a randomized head-to-head comparison, alectinib would be more effective than crizotinib as first-line treatment for patients with advanced ALK-positive lung cancer. Shown here is the study design for ALEX. This was a global study involving 98 sites and 29 countries around the world. A total of 303 ALK-positive patients were enrolled. All patients had advanced or metastatic disease and were in the first-line setting. Patients with treated or untreated brain metastases were eligible for the study. Patients were randomized 1-to-1 to receive either alectinib or crizotinib. The primary endpoint of the study was progression-free survival, PFS, based on investigator assessment. Secondary endpoints are listed here, and in the interest of time, I'm going to highlight just the primary endpoint and 3 of the key secondary endpoints: progression-free survival by independent review, time to CNS progression, and safety. So as shown here, ALEX met its primary endpoint and showed that alectinib is superior to crizotinib in prolonging progression-free survival. Median PFS was 11.1 months with crizotinib and not reached with alectinib. The hazard ratio was 0.47 in favor of alectinib, and this corresponds to a 53% reduction in the risk of progression. This difference was highly statistically significant with a p-value of less than 0.0001. Similar findings were obtained by the Independent Review Committee. Based on independent review, median PFS was 10.4 months with crizotinib and 25.7 months with alectinib, a more than doubling of progression-free survival. One of the key secondary endpoints in the ALEX study was time to progression in the CNS. Patients treated with alectinib had a significantly lower incidence of CNS progression compared to those treated with crizotinib. The cause-specific hazard ratio was 0.16, corresponding to an 84% reduction in the risk of having CNS progression. Now, as shown here, at 12 months, the cumulative incidence of CNS progression was 9% in the alectinib group, as compared to 41% in the crizotinib group. These findings show that alectinib can significantly delay disease progression in the brain compared with crizotinib. Now, on the right is shown another key secondary endpoint of the study, which is safety. Overall, there were fewer severe side effects with alectinib compared to crizotinib. As a result, fewer patients required dose reduction, dose interruption, or treatment discontinuation. In conclusion, the ALEX study is the first global head-to-head trial comparing a next-generation ALK inhibitor with a first-generation ALK inhibitor as first-line therapy for advanced ALK-positive lung cancer. This study met its primary endpoint and showed significantly longer progression-free survival with alectinib compared to crizotinib. There was a 53% reduction in the risk of progression. In addition, alectinib was superior to crizotinib in treating and in preventing brain metastases. there was an 84% reduction in the risk of CNS progression. Taken together, both the efficacy and safety results of this study establish alectinib as the new standard of care for patients with advanced, previously untreated ALK-positive lung cancer. Thank you.
All right, thank you, Alex. John, up to you.
Yeah. I view this as a watershed moment for the treatment of ALK mutant positive lung cancer. Often studies comparing different similar type agents will show incremental improvements. This one is really different because it's a dramatic difference in efficacy. If you look at the difference, more than doubling the time for cancer progression or death. But it is also accompanied by improved tolerability. The drug is better tolerated by patients. It requires dose reductions less often. And then finally, as Dr. Shaw pointed out, one of the most debilitating things that occur in these patients with ALK mutant disease are brain metastases. This is the most common sites for progression. And what's really impressive about this is the dramatic reduction in the risk of brain metastases occurring. You know, it's an 84% reduction in that likelihood, which is really an absolutely striking result. So advances often come at the cost of decreased tolerability. Here's one where, in terms of efficacy, tolerability, the sites of recurrence, it's a clear win on all those. Let me just try to give this a little bit more context. Prior to this moment, I'd say the biggest advance in the field was the study comparing crizotinib, the current standard for first-line ALK mutant disease, with chemotherapy. And that really was a major advance in the field. For that study, the difference in progression-free survival was 7 months versus 11.9 months, so about a little more than 4-month improvement in the time to cancer progression or death. So here now, when you see this more than doubling to over 25 months, that gives you an idea of what a dramatic advance this is. And so I firmly agree with Dr. Shor's conclusion that this is a new standard for first-line ALK fusion lung cancer.
Great. Just one quick biology question. Do these ALK-positive tumors have a greater propensity to metastasize to the brain than other non-small cell lung cancers?
Yeah. This is a question that's often debated, and the question is, do they go to the brain more often, or is it just because crizotinib doesn't get into the brain that those tumors remain untreated? And there have been some recent studies actually addressing this. I think there's some evidence supporting both. We know that the drug crizotinib doesn't get into the brain well, so any disease that is in the brain remains essentially untreated. But there are at least some suggestions that it may go to the brain more quickly.
Thanks. All right, we're going to move right on to our last presentation, and then we'll go to questions. So the final presentation will discuss results from a large phase 3 clinical trial investigating the addition of pertuzumab to adjuvant trastuzumab and chemotherapy for patients with HER2-positive early breast cancer. And to present this is Dr. Gunther von Minkwitz, who's president of the German Breast Group in Neu-Isenburg, Germany. Dr. von Minkwitz.
Thank you and good morning. It's my pleasure to give you a short overview on the affinity study, a trial that explores the role of pertuzumab, an antibody directed against HER2, that it inhibits the heterodimerization of HER2 with other HER family members like HER3 and HER4 in patients with early HER2-positive breast cancer. So we randomized over a 2-year period 4,800 patients that have confirmed HER2-positive status to be treated with adjuvant treatment composed of chemotherapy, trastuzumab, and pertuzumab in the experimental arm, and chemo, trastuzumab, and placebo in the control arm. The anti-HER2 antibodies were given for a total of 1 year, and we allowed several anthracycline taxane sequence regimens or a non-anthracycline containing docetaxel carboplatin trastuzumab regimen as a backbone. Based on the result of a previous trastuzumab study, BCRG-006, we expected a 3-year disease-free survival rate in the placebo arm of 89.2%. And aiming a hazard ratio of 0.75, we expected a 3-year IDFS rate of 91.8% for the pertuzumab arm. Here you can see the results. At 3 years, we see a difference, an absolute difference of around 1% between the two treatment arms in favor of pertuzumab, but you can also see that after 4 years the curves are separating even larger. Even at this early point of time, the stratified hazard ratio is 0.1. That means that there is a relative risk reduction with the introduction of pertuzumab of 19% in these patients. This result was statistically significant at a p-value of 0.045, and the number needed to treat in this overall population was 112 to avoid one relapse of disease. Subgroup analyses show that this effect of pertuzumab is very homogeneous all over these subgroups. None of the interaction tests were significant. I want to highlight 2 of these subgroups according to nodal status and hormone receptor status. So in the node positive subgroup, which was about 2/3 of the patients, the difference at 3 years is 1.8%, and the unstratified hazard ratio is 0.77. So here the relative risk reduction is 23%, and that was statistically significant. And the number needed to treat in this subgroup is 56. In the hormone receptor negative subgroup, about 1/3 of all patients, the difference at 3 years is 1.6%. The unstratified hazard ratio is 0.76, and the number needed to treat 63. Using a dual anti-HER2 blockade requires always a certain attention to cardiac toxicity. Therefore, we defined a specific primary cardiac endpoint of severe heart failures and cardiac deaths. These were observed in the pertuzumab in 17 patients and in the placebo arm in 8 patients. The treatment difference of 0.4 was not statistically significant. Looking into more asymptomatic or mild symptomatic LVF drops, there was no difference between the two treatment arms at all. Most of the grade 3 or higher adverse events were hematologic, but I want to highlight that the adverse event that was most different between the two treatment arms was diarrhea. 9.8% of patients in the pertuzumab arm had a grade 3 or higher diarrhea, 3.7% in the placebo arm. This was mainly confined to the chemotherapy period and was more pronounced in patients receiving the TCH regimen. In conclusion, the affinity study met its primary objective. Pertuzumab reduced the risk of IDFS events in 19% compared to placebo at a median follow-up of 45 months. The treatment effect was homogeneous throughout all subgroups. However, the node positive and hormone receptor negative cohorts appear to derive most benefit at the current point of time, and of course, this might change with longer follow-up. Cardiac toxicity was low and not different between the two arms. The incidence of diarrhea was increased in the pertuzumab arm, and it occurred predominantly during chemotherapy and with TCH. Continued follow-up of up to 10 years is planned, and it is important to assess overall survival, longer-term IDFS, and safety analysis. Thank you very much.